The socio-economic impact of chronic pancreatitis is significant. This is a British analysis which shows that Britain is spending $285 million per year. Those are the expenses for patients with chronic pancreatitis. Yeah? The largest part is the expenses for the pain, 638 million dollars every year, but also significantly the expenses for exocrine insufficiency, endocrine exocrine insufficiency, interventions, admissions. There is a similar analysis of the economic burden, but it's a study from Croatia which analyzed the expenses for disease-related undernutrition in Croatia, and they found also that the expenses are really high. Total costs are 97 million euros, that levels and almost 3.5% of the total Croatian national healthcare budget. Average cost per patient, 1,640 euro. Undernutrition and malnutrition. So it is a big problem, not only economically. Matthias Löhr, he has already presented the data of pancreatic exocrine insufficiency. What is this? Mild digestion due to reduced pancreatic enzyme activity in the intestinal lumen. But we have to take into account only a marked reduction of enzyme activity leads to mild digestion. If we diagnose this problem, it's quite easy and straightforward to treat, and we can use the pancreatic enzyme replacement therapy, oral supplementation of pancreatic enzymes. Pancreatic exocrine insufficiency leads to malnutrition, and this is our focus here. Yeah? This is a summary of the current European guidelines Matthias Löhr also mentioned, which is now in press. In case of clinical symptoms of maldigestion, nutrition, and or low fecal elastase, further diagnostic measurements should be performed to assess the level of malnutrition. So we always have to keep in mind malnutrition when we are treating patients with pancreatic exocrine insufficiency. And also patients with mild to moderate exocrine insufficiency have an increased risk for nutritional deficiencies. Yeah? Not only those patients with severe forms of insufficiency. And even subclinical pancreatic exocrine insufficiency causes malnutrition and may pose a significant risk for the patient. Complications of insufficiency, yes, diarrhea, fatty stools, everybody knows that. But the studies are varying, but 25 to 70% of the patients with pancreatic exocrine insufficiency develops diarrhea. It's a final stage. Importantly, and much more difficult for us, is malnutrition, which has a severe impact on the patient: weight loss, loss of energy, muscle wasting, increased risk of fractures, increased risk of infections. Yeah? So this is why we have to look. And the European Society for Nutrition, they published in 2002, a long time ago, the Aspen Guidelines Nutritional Screening. They said we have to screen all our patients coming to the hospital, because 1/3 of all the patients hospitalized are undernourished. So we have to screen all those. And there are ways to screen very easily and fast. It's not a big complicated process. And this is here also depicted here. All patients get a quick, brief screen. Are they at risk? Yes or no? And only those who are at risk, they need a standard individualized plan. Those who are not at risk but are in the hospital, they need a new screening, maybe after 3 weeks, for example. So this is how it looks like, a two-step process. Is there a risk? Low BMI. Has the patient lost weight during the last 3 months? Has the patient reduced dietary intake? Is the patient severely ill? And if so, then we have to go to step 2, the final screening. So who is doing this in your hospitals? Are you all doing this? Screening all the patients for adenoma? Who's doing that in your hospital? No one? Please no. So actually there are also studies which show it's easy and nurses can do it. So when nurses meet the first time the patients, they use those screening tools. And I'm German, but I'm living in Sweden now, and in Sweden it works very nice. Patients come to the hospital, the nurses screen every patient. Malnutrition has also an impact on pancreatic surgery. This is a study, 143 patients undergoing pancreatic resection, and the reason was pancreatic cancer. And this study showed that patients with malnutrition had a 4-fold longer post-operative hospitalization period and a higher morbidity rate. So malnutrition is not only in patients with pancreatic cancer, but also in other patients with pancreatic diseases, a significant risk factor for surgery. So we have heard pancreatic exocrine insufficiency, fat-soluble vitamins. It's also, everybody knows it in every textbook. But let's take a closer look. Is it really true, all fat-soluble vitamins deficiencies? Yeah? Vitamin A. So actually, the majority of studies have shown vitamin A deficiency is not a clinically significant problem in most patients with pancreatic exocrine insufficiency. The same for vitamin E. Some studies, 24% have vitamin E deficiencies. Clinically, not really that important. Vitamin K, up to 50% deficiencies, yeah? Between 15 and 56. But vitamin D is a problem. And actually, it's a worldwide problem. Yeah? Vitamin D deficiencies are now recognized as a pandemic. The major cause of vitamin D deficiency is not pancreatic exocrine insufficiency, it's a lack of sun exposure. And very few foods naturally contain vitamin D. And this is the reason that in many countries the foods are fortified. They have vitamin D additives. Yeah? So also in Sweden there are additives, and it's in milk. They add vitamin D in milk or margarine. Yeah? And how does it look like in Sweden, where I come from? So you know, in the winter time it's quite dark there. Every second Swede suffers from lack of vitamin D. And now they're discussing in Sweden that they should add also other nutritional products, vitamin D, cooking oil, rice, butter, yogurt products. This is a discussion now. Yeah? And synthesis, as everybody knows, depends on the sunlight, the exposure to sun, but also the chemical processes or steps in the liver and the kidneys. Yeah? Interestingly, it's not well defined what is really deficient. Most of the people now assume that less than 25 nanomoles per liter is regarded as deficiency. Yeah. And this is the consequence of vitamin D deficiency: fractures. And this is also important for our patients with chronic pancreatitis. Here are different examples: the vertebral spine, lumbar fractures, compression fractures, hip fractures, and luckily not all the patients have osteoporosis or fractures, but many patients have osteopenia. It's a step before osteoporosis. Yeah? This is a radiograph, yeah? Typical picture of osteopenia. And here you can also appreciate why those patients have an increased risk for fractures. Left side, it's a normal trabecular structure of a bone for vertebral spine. On the right side, osteoporosis. And here you can imagine that there's a high risk of fracture. So, and how can we measure bone mineral density? It's quite easy with a DEXA scan, dual X-ray absorptiometry, difficult word. Yeah, it's quite easy. It's a low. It's a easy. The exposure, radiation exposure, very low. So the endocrinologists are doing this, performing this at our institution, And this gives us a very precise notion of the bone mineral density, bone mineral content. So this is a study. They were looking for vitamin D status in patients with chronic pancreatitis and pancreatic cancer. And they found a very high percentage of patients with vitamin D deficiency. But very low percentage of those patients had vitamin E or vitamin E deficiencies. What happens when those patients were set on, received supplements, calcium and vitamin D? Okay. So this is another slide which is not shown, later shown. So all the patient groups was shown that the vitamin D goes up. So it's quite easy to treat them if I know the patients who really need vitamin D. We did some studies also. We have shown that fecal elastase correlates with bone mineral density. Low fecal elastase, low bone mineral density. Also other studies have shown that. This is a study from 2015. They were also looking for patients with chronic pancreatitis and for osteoporosis. And they were looking for a different panel of bone turnover markers, resorption markers, vitamin D, of course, but also cytokines and PTH. And they've shown 1/3 of the patients with chronic pancreatitis had osteoporosis. And the interesting finding, this osteoporosis was not only influenced by vitamin D or calcium, but also by smoking and by systemic inflammation in those patients with chronic pancreatitis. They have an elevated concentration of pro-inflammatory cytokines, so a chronic inflammatory stage, and this is also contributing to osteoporosis. Malnutrition in chronic pancreatitis results from exocrine pancreatic insufficiency, as I already said, but it's also multifactorial. Abdominal pain, especially after food intake, patients with chronic pancreatitis develop pain. So they don't eat, yeah? They stop eating. Then they use opioids, causing nausea, causing obstipation. Duodenal obstruction can be a problem, yeah, with a chronic inflammatory mass on the pancreatic head. But also those patients with chronic pancreatitis who continue to drink alcohol, they are depleted of nutrients. They only drink alcohol the whole day. But also, as I said, chronic pancreatitis is a chronic systemic inflammatory state, which is also contributing to malnutrition because of an increased metabolic activity. Okay, so what are the consequences of pancreatic exocrine insufficiency? Leads to malnutrition, as I said. So all the patients have to be screened for nutritional deficiencies in lipid-soluble vitamins. And we heard this in another presentation in the morning. What are the parameters we have to look for? This is also now a summary from the European expert meeting there. Prealbumin is a good marker, retinol-binding protein, vitamin D, but also the trace elements like iron, zinc, magnesium. So, which are the indications for pancreatic enzyme replacement therapy? Who has to get now the replacement therapy? The patient with pancreatic exocrine insufficiency with low fecal elastase, patient with clinical symptoms of malabsorption or laboratory signs of malabsorption. So that means also those patients without clinical symptoms of malabsorption, but laboratory signs of malabsorption need enzyme replacement therapy. So that's a little bit of a change in concept. 10 years ago or 15 years ago, we were looking on the clinical symptoms, diarrhea, bloating, abdominal pain maybe. But now it's more subtle, it's more difficult. We have to look for malnutrition. and the patient doesn't answer. If we ask the patient, do you have malnutrition, he will not say yes or no. So it's a little bit more difficult for us. So this is also named. So what is the dose, the optimal dose? And here is again, the summary of the European recommendation. A minimum lipase of between 40,000 to 50,000 is recommended with main meals, and half of it with snacks. Yeah. And here is a study. It's over a time span of 1 year. Patient received enzyme replacement therapy, quite a high dose, 80,000 units 3 times a day, and 40,000 for a snack, quite high dose. And then there was a study from India, published 2013, and then they were looking for the parameters stool frequency, body weight, body mass index. And here you can see the daily stool frequency were continuously going down. The body weight went up. The people gained, so a medium 5 kilos during this year. And of course the body mass index also in parallel went up. So stool consistency was better, less diarrhea, flatulence was better, abdominal pain went down, and also quality of life scale was also applied, was also improved. So it has an effect if the patients get the enzymes. This is the quality of life. Yes. So what is the schedule? How do they should take the enzymes? Yeah, and this is a study from Spain, from Professor Dominguez Munoz, and he compared different schedules. Patients who had taken their enzymes before the meals, or just after the meals, or along with meals, so together with meals. And he found out it was the best, here down, if the patient take the enzymes together with the meals. Yeah? Mild digestion was lowest when the patients took the enzymes together with a meal. So it was lowest when they took it before. Yeah? That's interesting because I think many people said you have to take them before. Yeah? And if, especially when there is a higher dose, then it's good to split it. And how should the efficacy of enzyme replacement therapy be evaluated? So it's quite easy, it's quite straightforward. We have to evaluate it clinically. We have to talk to the patient, ask him, what about the diarrhea, weight gain, abdominal symptoms, but we should also look for the nutritional parameters. It's also important. What should be done in cases of unsatisfactory clinical response? Later on we will hear a lot more about this. Yeah? Of course we have to look for the compliance if the patient really takes the enzymes, but if you really do it, we have to increase the dose. We have to double the dose of PPI. And only in those cases where this strategy fail, we have to look, is this really exocrine pancreatic insufficiency, or is something different causing the diarrhea? Yeah. So either we can double the dose, or we can combine the enzymes with the PPI. So there's also a study, yeah, maybe all the patients getting enzymes should get a combination with PPI. Yeah? But it's again a study from Spain, and he has shown only the patients who are not responding to the enzyme replacement therapy have a benefit if we combine it with PPI. So not all our patients getting enzymes need a PPI. So, summary therapy of malnutrition, we have to detect it early, we have to supplement the enzymes, we have to assess and also to correct the nutrient deficiencies. So they need the vitamins, they need the micronutrients, and we have to be careful and we have to check if really patient have an adequate dietary intake. So we send our patients also always to a dietitian, and the dietitians, they talk to the patients and give them also recommendations. So this is, I think, also an interesting study from the Netherlands, and this study, they showed how is it the patient, how are they treated, the patient with exocrine insufficiency. And the patients were contacted, and 70% of the patients still reported steatorrhea-related symptoms despite of treatment, which is a very high number. Only 25% of the cases were referred to a dietitian, and nearly 60% were kept on a restriction of fat, which nowadays really nobody recommends. So the people should continue to eat fat in combination with enzymes, because fat is a good fuel or a good source of calories. If they really are restricted always on fat, they don't get enough calories. Yeah. So this is important. We also had a small project where we also contacted our patients in Sweden, and it was very interesting for us to get in contact with them. Many patients had a quite low dose. Then the patients told me, yes, when I wake up in the morning at 6 o'clock, I take my medications for blood pressure and my blood for the pancreas, and then I sleep a little bit, and at 9 o'clock I have breakfast. Yeah? So it's very interesting to talk to the patients. Yeah? But now look a little bit what the other guidelines in Europe recommend regarding the dose. Yeah? And the Belgian consensus recommendations published in 2014, they don't specify any dose. Yeah, they only say we have to treat the patients with enzymes. The Italians, what do they say? Yeah, they recommend 25,000 to 40,000 units for every meal. And it's interesting, they say dosage should be tailored according to the severity of maldigestion and fat content of the meal. Yeah? Tailored. And this is actually what our patients do. If they said, oh, if I eat a lot more fat or more, a big cheeseburger, McDonald's, Big Mac, so I take an extra creon. Yeah? So they are doing that. Yeah? The Italians, they say also basically 40,000 proved to be successful and 20,000 for a snack. The Spanish experts, what do they say? Minimally pass 40,000 to 50,000 is recommended at each meal, half dose in combination with snacks. It should be given in the middle or at the end of meals. The Germans, what do they say? Lower dose, 20,000 to 40,000 units, and with a snack, 10,000 to 20,000. Level of evidence, 1B, recommendation B, strong consensus. Yeah? So their recommendations are variable. And the Swedish guideline, which is now also in preparation or almost in press, recommends also 40,000 to 50,000. So there are different recommendations. They are quite strict, and maybe in the future we need more evidence that we really can tailor the dose to the individual patient. I think currently we don't have so many good studies which can really say or give us a tool or help to give a recommendation how we can individualize the enzyme supplementation for our patients. Thank you very much.
Thank you very much, Dr. Haas, for the nice presentation. Are there any questions? Would you recommend to measure vitamin D, A, and E in every patient with chronic pancreatitis, even when he has no signs of malnutrition?
I think D, yes, because irrespective of the pancreas, vitamin D insufficiency is so widespread. So definitely yes. A and E, I would be a little bit more constrained. Maybe in those patients where really have malabsorption signs, malnutrition signs, low BMI, I would also go for it. But in the first place, I think vitamin D is really important.
But there's no evidence regarding clinical outcome.
Yeah, this is true. Yeah. So we have the epidemiological evidence that that vitamin D insufficiency is widespread and has an increased risk for osteoporosis and fractures, but the intervention studies are lacking.
I see hundreds of patients with chronic pancreatitis, but osteoporosis is no clinical problem.
That's good for them, yeah?
Okay. I don't see any further questions. Thank you much again.